Welcome, everybody, to the Independent Sage Friday briefing. At the start of the pandemic, public health advice was condensed into a simple 3-point message: hands, face, space. Over the last 18 months, we've learned a lot more about how this virus spreads, predominantly via airborne particles and droplets, and that transmission can be significantly reduced by improved ventilation in enclosed spaces. As children and students return to classrooms and lecture theatres, and more people are returning to the workplace, it's becoming clear that good ventilation can play a vital role in suppressing the spread of the virus. But what do we mean by good ventilation? Is it enough just to open a window, or do schools, workplaces, and other venues need to install air filtration systems and carbon dioxide monitors? So to join us in the discussion today, we have Carl van Keersbilk, who's an IT expert with a long-standing interest in education and ventilation. Before we hear from Carl, though, Professor Christina Pagel is going to take us through the latest facts and figures this week. Christina, over to you.
Thank you. Right. So, I'm going to be quite quick on the numbers today and just go very briefly through vaccinations, cases and hospitalizations. And then I'm just going to end by introducing a new Independent Sage statement that we are releasing today. So on vaccinations, I just want to show one plot really from the Public Health England surveillance report that came out yesterday. And just to show that we've now given a first dose to more than half of 16 and 17-year-olds, but in the 2 weeks since rollout was approved for 12 to 15-year-olds, that program doesn't really seem to have started yet. And so we're still only 10% of 12 to 15-year-olds, or less than 10%, have received a first dose in England. Looking at cases, overall in the UK, we've been kind of in the mid-30s. It does mask quite a few differences by nation. So England and Wales have been going up, Scotland and Northern Ireland coming down, although their decline is slowing. Normally, I would also be looking at positivity rates, so the proportion of people who test positive. But positivity rates right now are a little bit difficult to interpret, and I'll explain why. So from Public Health England surveillance report that they released yesterday, they have a graph of people who get a test and say, I'm getting a test because I have symptoms, and then people who get a test because when they don't have symptoms, so presumably they've tested positive on lateral flow. And you can see that a few weeks ago, 40% of people who said they had symptoms of COVID ended up testing positive for COVID, and that has dropped really steeply to only 20%. And what that is that there's a big cold going around. So this is the percentage of people testing positive for other respiratory viruses. This is rhinovirus, and you can see over the last few weeks that's really been shooting up, and it has very similar symptoms to COVID. And so basically people don't know which they have, and then they get a COVID test, and so it makes the positivity rates really hard to interpret. But I also just want to urge you that if you have the symptoms of a nasty cold, sore throat, cough, runny nose and so on, it might be this cold or it might be COVID. So please do still get a PCR test. Please don't just assume it's one or the other. To really understand the case rates, you do kind of have to look at it by age, because we're seeing very different epidemics now by age group. This is case rates in England to the 25th of September, and this is going back to a full year ago now. And you can see that the rates in 10 to 14-year-olds, particularly the percent, people testing positive, is just so high. So over 1.4% of 10 to 14-year-olds have tested positive in just the last week in England. Other age groups that are going up are 15 to 19-year-olds and 5 to 9-year-olds. Now, a year ago, we had this big spike in the 15 to 19-year-olds as they went back to university. That has just happened in England. So it'll kind of be interesting to see whether you get another university spike or whether actually you don't get it, because a lot of them have now been vaccinated. What we're also seeing is the 20 to 29-year-olds who've had such high rates in previous peaks now have almost some of the lowest rates, and that is really showing you the benefit of vaccination, as most of this age group is now vaccinated and has had high previous infection. What you are seeing as well is that the generation who are most likely to be parents of school-aged children, 30 to 59-year-olds, are going up as well. And they started going up about a week after their kids really started going up after the beginning of term. So it does look as if some of those infections are now moving in to their parents. The Department for Education publishes absences from school due to COVID and other reasons, but they've moved to doing it every 2 weeks. And so the last time they published that data, when over 1% of students were absent through COVID, which was already a record, was the 16th of September. And so we just do not know yet what this enormous spike, what the impact has been on children attending school, or in fact on their parents being able to go to work. And since the 16th of September, at least 125,000 children aged 5 to 14 years have tested positive. So, a really large number of children. It's not just testing. The ONS infection survey data released today on people testing positive, it tends to be a little bit lagged. So it's kind of slightly further back than the case data. But they're also showing really high increases in secondary school-aged children in particular. Almost 5% tested positive in the week to 25th of September. And this is a random sample, and that's higher than it's ever been. So it's not just about testing. Cases in children are really now at their peak that they've been throughout the whole pandemic. Looking at hospitalizations, this is good news. It's coming down in all nations. But again, you do kind of have to look at different age groups and thinking about case rates. So if we look at the oldest groups who tend to, who are much more vulnerable to COVID, the good news is that firstly, they're way lower than they were at peak, but they've also been pretty flat in the over 85s and coming down over the last few weeks in 65 to 84-year-olds, which is really good news because that had been creeping up throughout the summer. For adults aged 18 to 64, there's been it was very flat over the summer, and that has now been coming down, which is really good news. But what we don't know is whether the recent increases in cases in 30 to 59-year-olds is going to start either flattening this off or pushing this up in the coming weeks. For children under 18 who typically have not been vaccinated, apart from the 16 and 17-year-olds, the picture is quite different. So the yellow line is 0 to 5-year-olds, and the red line is 6 to 17-year-olds. So 0 to 5-year-olds have been coming down since the end of August, and that has continued. But 6 to 17-year-olds have been going up pretty steeply over the last couple of weeks in terms of hospital admissions. And so, yes, the number of hospital admissions is much, much lower than for adults, but it is still there and it is still going up. In fact, they're the only age group now that is seeing significant increases in hospital admissions. And just finally, I just want to show you a hotspot. So overall, case rates in children are pretty high all over England, while case rates in non-parental generation adults are not. But there are hotspots, and Kettering is currently the hotspot in the East Midlands in England. And this is case rates by age to 25th of September since last September. And you can just see quite how high this is. So over 6% of 10 to 14-year-olds in Kettering tested positive last week. I mean, it's more than 10 times higher than previous rates. And it's also extremely high in 5 to 9-year-olds and 15 to 19-year-olds. And it's also driving up the 40 to 49-year-olds, again, the parental generation. And in fact, there are over 800 cases per 100,000 per week. And that's higher than it's ever been in that age group for adults, despite the fact that the high vaccination rates. So that's all I'm going to say about the numbers today. I just want to briefly introduce a new statement. And this is basically on the JCVI recommendations for vaccination in children. So, and what this statement is asking for is basically more transparency from JCVI about how they came to their recommendations. So they published 3 statements over the summer in July, August, and September, kind of gradually changing their recommendations. Now, their code of conduct says that mathematical modelling studies, which includes risk-benefit analysis, should include all relevant assumptions and sources and a full description of the methodology. And their most recent statements just don't contain that, unlike the statements they published on, say, vaccine dosage or the priority groups. So I'm just going to quickly highlight, what is missing. So if you want to do a kind of a risk-benefit of vaccination, you have to first understand, what assumptions are you making about how bad COVID is going to be in children? And their September statement, the most recent statement, was particularly concentrating on healthy children, so children without underlying health conditions. So the first thing is, if you're considering hospitalizations, which they did, is what is your chance of needing hospital if COVID positive? And JCVI, in earlier statements, had quoted a rate of hospitalizations per million, didn't say per million what, and then have not provided any estimates disaggregated by healthy or underlying conditions, and did not provide any risks in the September statement. They also looked at intensive care. And again, they partly did this. They gave risks disaggregated by healthy and unhealthy, again, did it per million, not clear what that per million means, and also not clear if that includes post-inflammatory pediatric inflammatory multisystem disorder, which is kind of a bad outcome from COVID, which is the next one. And again, here they provided a statement back in July of an estimate of 5 cases per 10,000 infections. This time they did give a denominator, but didn't update it in September and didn't say what rate they assumed for healthy children, which is what the analysis was for. And we do know that PIMS can affect healthy children. And we also know that it disproportionately affects children from ethnic minorities. You also need the chance of dying if positive. So again, they didn't really provide an estimate for what rate they were using for that, particularly disaggregated by healthy or unhealthy. So although many children who died do have underlying health conditions, not all of them do. And in fact, they didn't even consider that as an outcome in September. And finally, your chance of developing long COVID, which we know is an adverse outcome. We know that it's hard to measure and has lots of different estimates, but nonetheless, they gave an estimate in August where they said 1 to 10% of children with COVID might end up with long COVID, and said that vaccination was expected to provide benefit, but then they didn't mention it in September. So once you've got the risks of COVID, you need the risk from the vaccine. How dangerous is the vaccine? So they were concerned about the chances of developing myocarditis, which is heart inflammation, and they did provide those risks. And then you also, if you're looking at how many hospitalizations have you prevented, say, well, what is your chance of hospitalization because of vaccination? And they did not provide that estimate. And then you need to say, okay, well, what am I expecting to happen in the future? Because this is a really important bit, because if you vaccinate a certain number of people, the harms of that are the same, regardless of how much COVID is around. But the benefit of that program depends on how many people you prevent from catching COVID. So if there's no COVID, there's no benefit. If there's loads of COVID, there's loads of benefit. And so it's really important when you're doing risk benefit to say, okay, well, how many people am I assuming are going to get it without vaccination? And so how many cases am I preventing? And they didn't really give any details of that. And finally, they didn't give you any details about how they then used all those different numbers to come up with their tables that they provided in September. And so really what we're asking for is just that they release that information. So it's not about us saying, hey, well, it's the wrong conclusion or not. It's about saying, well, we don't understand the conclusion because we haven't been given the information as to how it came about. And then to also prepare now for consideration of vaccination in children under 12, because we do know that the first Pfizer trial is completed, that it is likely that vaccines will be approved in the age group. So it's kind of, can they please set out now how they're going to consider whether to do that later this year? And that's all I'm going to say. Thank you.
Thank you very much indeed, Christina. Now, those of you who've been following Independent Sage throughout the pandemic will know Christina Pargle very well. She's Professor of Operational Research at UCL, where she applies operational research, data analysis and mathematical modelling to problems in healthcare specifically. And she's been part of Independent Sage since the very beginning, helping to produce reports on the numbers, which she presents at most of the weekly meetings, working on other reports which are published on the Independent Sage website, talking to the press, and also sharing science on social media. And I'm absolutely delighted to say that she's just been awarded a special recognition award for science communication in the BMJ Awards 2021 in recognition of all her work with Independence Age. This is such a prestigious award, and it shows the high esteem in which Christina's held by the medical and scientific community in the UK. So huge congratulations, Christina. Now, before we move on to discussion with our special guest, we're going to ask Professor Martin McKee to introduce a short presentation in which Tricia Greenhalgh, Professor of Primary Care at Oxford University, has kindly pre-recorded for us. So Martin, over to you.
Okay, thank you very much indeed, Alice. And let me just hope that I can get this to work. It should hopefully play. And you'll tell me if you can see it.
I'm going to give you a little talk now about ventilation and filtration, including the use of carbon dioxide monitors. So, as I've said, this virus is present in the air. It enters the air when we breathe out. When someone who's infected, whether they know it or not, exhales, those viral particles will then become suspended in the air and be potentially available for other people to breathe in. So if we're indoors, what we need to do is ventilate. We need to open the windows. We need to open them wide. We need to perhaps open a door as well to get a through draft. Or if the room has two windows on opposite sides, that's usually a very good way of getting a through draft. Now, we monitor how well we're ventilating a space by using carbon dioxide levels. And this isn't really very hard. You may remember from school that carbon dioxide is produced by us as humans, and we breathe it out in a small proportion in our exhaled air. And what that means is when you measure the carbon dioxide levels in an indoor space, the higher the level, the higher the proportion of exhaled air in that space, in the air in that space. Now, of course, it's a proxy measure, but as a rule of thumb, a very well ventilated space will give you a carbon dioxide level below 700 parts per million. Outdoors, it's about 420 parts per million. That's as good as it's ever going to get. Now, as more people breathe out into that room space, and if it's not ventilated, the levels are going to go up. 700 to 800 perhaps is moderately risky. Between 800 and 1200, that's really getting quite troubling, and above 1200, you don't want to be in that room because those levels indicate that there is a high proportion of exhaled air, and some of that exhaled air may contain virus. So that's, broadly speaking, the carbon dioxide monitoring. Now, that's no good if the room is actually has an air filter, because the other way, apart from ventilating, that you can clean the air in a room is by filtering it. And the filtration doesn't remove the carbon dioxide. So if you're using filtration, you can't use CO2 levels. I should say that the levels recommended by the government through the Health and Safety Executive for what level do we need to actually take action on are a little bit higher than the ones I've recommended. And that's because they were set historically for a completely different reason, largely to make the building feel less stuffy, to make sure that people weren't feeling tired or having headaches, and to get rid of the smells from human body odor, that kind of thing. Now, that's a different use of carbon dioxide levels from just giving us an indicator of the exhaled air. So we do need to bring those levels down. And I would encourage you to use a level of 700 parts per million to prompt action to either ventilate or filter. So let's get on to filtration. Many buildings in the UK do have internal filtration systems, and they are covered by a set of regulations on which I'm not an expert, but I've learned a little bit about them. They have something called a MERV rating, which is minimum energy efficiency rating. And the MERV level in most buildings is about 8, but we really need to push for a MERV level of about 13, which indicates a higher level of filtration. So MERV 13 is the thing you need to think about when you're looking at the quality of filtration in your building. You also need to make sure that whatever's removing the air to filter it, or removing the air, doesn't just recycle it through an air conditioning system. So it's fine if it's filtered out, but not if it's recycled into the room. Now, the other thing to talk about is portable air filters, because many buildings do not have inbuilt filtration systems. And so what we have to do is buy a portable air filter, plug it in, and then stick a filtering device, what's called a high efficiency particulate air, or HEPA, HEPA filter. And once you've got yourself a portable air filter with a HEPA filter inside, then you will find that the virus will be filtered out at a very high level, and that room will be much safer. For example, there's one study recently that showed that if people in the room are wearing masks and that you're using HEPA filters, you reduce by about 30-fold the levels of airborne particles in that room. So the combination of masking and HEPA filters is a very, very good way of making rooms safe. Hope that was helpful.
Good, thank you very much indeed. Thanks, Trish. So we're talking about ventilation today, and I'm delighted to be able to welcome from Belgium, Carl van Keersbilk, who has been working in education, and in more recent days, obviously because of the pandemic, has taken an interest in ventilation in schools. But before we get on to that, Carl, maybe I could just ask you, it's always helpful to see ourselves as others see us. Having seen Christina's presentation on schools and children in the UK, you've been vaccinating 12 to 15-year-olds since July in Belgium. It was a relatively uncontroversial decision, I think, and you have been putting CO2 monitors in buildings and so on. But maybe tell us what you think, your reflection and looking at the data that you're seeing from the UK. And your microphone's on. Great, thanks.
Yeah, well, I see, when I compare to the Belgian data, I see that the only age where cases are going up in Belgium is at the youngest ones, so the kids below 12 years, because starting from July, we have been vaccinating kids between 12 and 18, and yeah, it has been a very popular decision. So our vaccination rate is very high. Certainly in Flanders, there's a big difference between Flanders and the other states in Belgium, Wallonia, and certainly Brussels. In Brussels, yeah, the figures are rather bad. But in Flanders, we see that the vaccinations are very popular, and yeah, that makes that the last months in the number of cases we see, yeah, it's not moving. It's moving horizontally. So there is no descent. There is no climbing on the secondary school ages. So only for the primary schools, we see that it's going up.
And what's happening in the schools themselves? Because we're having a lot of absenteeism. Children are coming out of schools. Classes are closing down because of the scale of the infection. Are you seeing that? I guess you're not seeing that in Belgium then, from what you're saying.
Well, we are seeing some cases, some class closing down. Politics found that it was too much, but when I look at the data, I don't have the impression that too many classes are closing down, are being put in quarantine. But since they found that the levels were too high, well, the decisions around when a class has to be put in quarantine, well, these rules has been changed this week. So formerly it was there was a quarantine for a whole class when they found 2 cases within 2 weeks within a class, and now it has been changed into 2 cases within 1 week. So only when 2 cases in one week, the class is being closed.
Okay, well, that's still quite different from what's happening here, where there's the rules have been relaxed very much more than that. But you're as you say, you've got the high levels of vaccination. Now, the CO2 monitors, you've got CO2 monitors by law in a number of settings. Could you tell us where the CO2 monitors have been installed?
Yes. So since June, the federal government, because education is Flemish or for Wallonia, the CO2 monitors must be installed in, for instance, restaurants, pubs, and fitness centers. And since today, they also must be installed in, for instance, dressing rooms of where kids and people do sports.
And what happens if what levels do they use to trigger action, and what happens if the level goes above a certain threshold?
Yeah, well, there is an old law in Belgium. It's a labor law which has been altered in 2019. So in the summer of 2019, just before the pandemic, it was maximum 800 parts per million CO2 in every place where someone is working. This has been altered to 900 parts per million. And so 900 is currently the level where every employer should remain below. Alternatively, 1200 is accepted, but then he must prove that extra interventions give the same kind of protection as 900 parts per million does. So, as being told in the YouTube video before, air purification, for instance, is a good way to remove viruses from the air and get the same kind of protection.
But there's a widespread recognition of the need for either ventilation or filtration. That seems to be accepted, and it seems to be being rolled out, being implemented. Yes.
Yes, it's clear that in Belgium and the federal government, the health department is going forward to put ventilation in place and sees the importance of ventilation. I see that in the states, so Flanders and Wallonia, they are much more reluctant to go ahead for ventilation. But yeah, it's certainly in education, it's very important. We know already since when I look at the several research that has been done, I refer to 2007 research by the Belgian consumer organization, like you have which in the UK. It found out that in classes, 60 classes, they investigated, the norms were not kept, so most classes went way above the norms. In 2009, new research in primary education found out that only one class out of the 90 which have been investigated was okay with the legal norms. They found values until 8,000 parts per million. And then again, at that time, 2009, there is a government agency which is responsible for the school infrastructure. And at that time, in 2009, because of these really bad data from that research, they advised to put CO2 meters in classes. So 12 years ago, nothing has happened with that advice. Then 2009, again, a new research, 50% of the classes way above 2,000 parts per million. And now we're in full pandemic, and still, in education, the Minister of Education doesn't want to put CO2 meters in classes. School can buy them themselves, but he doesn't want to force it.
Yeah, so you have challenges just like we do. But you've looked in Belgium at CO2 levels and learning outcomes and concentration and things like that too. Can you say something about that?
Yes, well, there's a lot of international research showing that low CO2 levels not only have an impact on absenteeism because people get ill of when the CO2 levels get too high because of viruses and bacteria, but also the low CO2 levels are needed for cognitive performance. So we know that when CO2 levels go up, the cognitive performance goes down. And certainly in an environment of schools where the Convention of the Right of the Child says that every child has the right for maximum chances for maximum development, well, that's, too high CO2 levels are hampering and are not compatible with this fundamental right of children.
So one of the arguments that we hear in the United Kingdom is that there's a sort of, you can either have restrictions on the transmission that would stop the transmission of the virus in schools, but if you do that, it will interfere with learning and so on. And what you're saying is you've got a win-win situation, because better ventilation, CO2 monitors and so on, not only reduces the risk of transmission of COVID, children getting COVID, getting long COVID, but it also actually improves the educational environment for them as well.
Yeah, and it reduces absenteeism of the kids themselves and of their teachers, because also in Belgium we have a lack of teachers. So I don't know if there's a shortage of teachers in the UK, but also there this has an impact on that factor also.
Yeah, I think we have a shortage of everything at the minute, actually. So it's not just teachers. And just going back to the CO2 monitors and the other settings, could you just say something about the inspection regime? Because one of the things we've seen in the UK in recent years has been a deregulation and a removal of inspection regimes in terms of health and safety. Our health and safety executive has been cut back very, very much. So how has it been working in the different settings? Because I think there are some settings that are responsibilities of one ministry and some of another.
Yeah, that's very difficult in Belgium. So for the restaurants and pubs, for instance, it's the health department that has to control the presence and the values of the CO2 meters. So since this has been voted in June, there have been 3,000 checks by the inspection. The fitness centers, for instance, have to be checked by the Department of Economy, and the Department of Economy only checked 2 fitness centers since June. But yeah, there was also, for instance, you also have the care homes for the elderly. And it's the legal norms, which I explained, so the 900 or 1200 parts per million, because the labor law exists for many years, and people are working there. I had contact with the spokesperson of the Flanders department ministry, which is responsible for that. So that's, again, another department. And then, you see the umbrella opening. They say, well, the labor law, that's federal law, so we don't check the federal law. And there's a federal act, there's a Flemish act telling that CO2 levels may not be higher than 500 ppm above the level measured in the outside air. So if the outside air, for instance, is 430, they may have inside they may have 930, but they don't check on that also because there is no intervention level defined in the law.
Okay, so the lesson from all of that is, of course, you need to put these things in place. You need to have the policies, but also you need to have the implementation and the inspection. Carl, thank you very much indeed for that. I'm going to stop the questions at this point because there will be questions coming in from those who are participating, who are watching, which I'll hand back to Alice. And some of them may be for you that are specifically about Belgium and ventilation in schools, and some of them will be, I suspect, for the rest of us. But thank you very much. Dank u wel.
Thanks very much, Martin, and thank you, Carl, as well. It is really useful to have that perspective from another country. I think it it's useful to look at the contrast, isn't it, and to see where we might be doing things well or might be able to do things better. So now we're going to start taking questions from press and public. And first up, we've got Rachel Curley from the National Education Union. Rachel, are you there with your question?
I am. Thank you, Alice. So this is from the National Education Union, as you say. So double vaccination has changed so much, but children are still contracting COVID and having their education significantly disrupted. And according to this week's ONS statistics, 1 in 22 secondary school pupils had the virus last week, and that's up from 1 in 36 the week before. And we hope the rollout of the single-dose vaccination will help to reduce transmission, but that will take time. In the meantime, in Scotland, cases among secondary school children do seem to be falling. But in Scotland, in schools, there's still mask wearing, and siblings of children who have the virus don't return to school until they've had a negative PCR test. Whereas in England, those children return to school and are only requested to have a PCR test. So my questions from the NEU are, what measures should the government in England put in place now in schools whilst the vaccination is taking effect? Should they reintroduce mask wearing in schools and the same regime as in Scotland over close contacts? Should they ask schools to pause big gatherings? And what steps should they be taking on ventilation and HEPA filtration? Thank you.
Thank you very much, Rachel. So a lot of questions there, and of course, schools have reopened in England with no mitigations, no bubbles as we go back this autumn. So, what should they be doing as this vaccine rollout starts? And as we know, it is, as we've seen from Christina's figures, it's a very, very slow start to that vaccination rollout in the 12 to 15-year-olds. Who would like to start with Rachel's question? I mean, those questions almost answer themselves, I think, Rachel. Christina, you're going to start.
I mean, I think they have to go back to at least the mitigations we had in place at the beginning of the summer term last year. I mean, I can't quite understand why if it was considered reasonable to have masks back in May, why it isn't now when cases are so much higher among children and it is disrupting their education. And to also require PCR negative tests from household members who have positive, who have house members who are positive. On the ventilation thing, I think Carl would be the right person to talk about what kind of ventilation measures there should be.
Thanks, Christina. Yeah, Carl, what do you think schools should be doing then while the vaccination programme is rolling out?
Well, I suppose that just like in my country, most schools don't have any mechanical ventilation installed, and getting those systems installed will take many months, not to say years. So I think my position in Belgium is there is a quick win with the combination of CO2 meters and mobile air purification. A mobile air purification system which can change 600 cubic meters an hour. When you install two or three of these devices in a classroom, you get an environment that is way safer than it is the case now. And you can make them work at maximum force, but then you will have trouble with the decibels. So when you're putting 2 or 3, you're getting normally enough cubic meters, which has been filtered out, and keeping low the decibels. So I think that's what should be done in every school which does not have mechanical ventilation. When you do have mechanical ventilation, there a CO2 meter is useful to do some checks from time to time, but there I don't think a CO2 meter needs to be available the whole day or the whole week. So.
Thank you very much, Carl. I mean, it is quite shocking, isn't it, to hear that that rate of positivity as well, 1 in 22 children with COVID. I mean, that means on average that there is a child in every class, at least one child in every class with COVID. Zubaida, I think you wanted to comment here, Dr. Zubaida Haque.
I think we also need to consider that, as my colleague Christina pointed out earlier, that the rates are not the same across the country. In some areas, it is eye-wateringly high, with areas such as Kettering, where 1 in 16 pupils, so that's almost two pupils in every class with COVID. And of course, that's those who have been identified with COVID, let alone all the other children that they're infecting. And that, of course, is also about who else those children go on to infect, which is teachers. We know that in school in Derbyshire, approximately 18 teachers were off in one school in Derbyshire. Now, this whole notion that educational disruption isn't happening is a complete lie. We know over 120,000 children have been off school in the last little while with COVID. And we know that for 10 to 14-year-olds, we have the highest infection rates ever in this pandemic and among all age groups. It is unacceptable. It's absolutely unacceptable. It's unacceptable to be deliberately infecting children, and it's unacceptable to be exposing the school workforce, their parents, their grandparents, all over again to COVID, because we know what the impact of COVID is. Absolutely unacceptable.
Thank you, Zubaida. I'm going to come across to Professor Gabriel Scally first, and then there's a couple of other people who want to stick their oar in as well at this point. So, Gabriel,
Thank you very much. I just wanted to say that, we should be learning from other places in this. In California, only in August passed really great legislation and a hugely well-funded program to improve ventilation right across the whole of the school estate in California. And they go into very substantial detail on what they're prepared to fund. And that includes the CO2 monitoring and how it should be positioned, what level it should be set at, that it should be alarmed, that it should operate 24 hours a day, what should happen when those limits are exceeded. Also in ventilation, funding for the installation of proper ventilation systems. Actually, they also allow for stopping ventilation systems operating. And all ventilation systems should be assessed to make sure that they are delivering appropriate ventilation and levels under 1100 maximum at all times, et cetera, et cetera. And it is just so well funded, well codified. And that is exactly what we need. And we need a government that's prepared to do that. My other point is, I think there is a real responsibility on the unions as well. There is a legal requirement under the Health and Safety of Work legislation that employers must ensure adequate supplies of fresh or purified air to employees who are working in a confined space. And we actually do need a program to ensure that that legislation is implemented, is being carried out. And the trade unions have a fantastic role, I think, with their members in ensuring that employers are living up to their legal requirements. Thank you.
Thank you, Gabriel. Professor Anthony Costello.
So we knew about CO2 monitors in June. We knew about the safety of vaccination for 12 to 16-year-olds in June, approved by the Medicines Health Regulation Authority. We could have done this. And then we had in early July, was it, the replacement of our Secretary of State, Sajid Javid, who is the most libertarian MP in the Conservative Party, supports Ayn Rand and her philosophies. And he said, lift all restrictions. And so over the summer, eventually, Gavin Williamson did come up with £25 million to buy CO2 monitors in late August. So our children are unvaccinated. And I've been horrified by the figures from Carl and Trish, that, we should be around 700 to 800 parts per million of CO2. I've just looked online to try and find some figures for classrooms in the UK, which seem to be regularly above 1,500. And that's considered the green zone if you're below 1,500. So I think we're, not only are 90% of children in the world breathing unsafe air outside the classroom, and in many urban centres here, we've got, sulfur dioxide, nitrous oxide, and all of the particles that can damage children and cause asthma and all the rest of it. Inside the classroom, we almost certainly have most of our children breathing unsafe, virus-contaminated air. We're seeing an explosion in cases. And I'm actually really shocked from what I've heard today. And I think it's yet another example of neglect of prevention for our children. I'm really horrified.
Thank you very much, Anthony. I mean, I think it probably was you last year, around this time last year, talking about the mitigations that were, or probably better put, were not in schools, and that if you were going to pursue herd immunity through infection, then that was how you would do it. Do you suspect that is still part of the plan, given that all mitigations have been dropped?
It's absolutely open season. I don't think all of the medical advisors agree with it, but they have to follow the politicians. Sajid Javid is absolutely clear about this. He wants us now to just live with the virus. There's been no effective messaging about masks. I've sat on trains yesterday where half the people were not wearing masks. I mean, it's just a free-for-all, and there's no clear messaging about anything. And the consequence is that hundreds of thousands of our children are going to be infected. And as a parent, I mean, fortunately, my children are older than school now, but I think it's horrific for parents. I mean, you've got children, Alice, and I'm sure you feel that you can't protect them. I think it's really shocking.
Yeah, it is. It does put parents, it puts teachers, it puts school unions in a very difficult situation. I think Professor Stephen Reicher, you wanted to comment on this question of Rachel's as well.
Yeah. Although I'd just say to Anthony, I'm in Edinburgh at the moment. I came down to Edinburgh this morning on the train in Scotland, and there are regulations for masks on trains, and about 90% of people were wearing masks. So that shows that the regulations make a real difference. I mean, the great questions, and the short answer, of course, is yes, yes, and yes. And all of these things are outlined in our schools plan, which was updated and re-released a couple of weeks ago, and I think it's worth looking at that. But I just want to raise a few fundamental points which I think that this raises. The first and the most important is just to reiterate the message at every point that infection matters. One of the most pernicious things going on at the moment is that the government, sometimes explicitly and sometimes implicitly, is giving the message that infection doesn't matter, that they regard with equanimity the notion that all children, all unvaccinated children in particular, are going to get infected. And that sends a message of it doesn't matter. And I think it's quite clear that it does matter. It matters in terms of the disruption. It matters in terms of hospitalizations, as we've seen from Christina's figures. It matters in terms of transmission into the community. So I think the first point we need to make is this is part of something bigger, and we do need to say that infection really does matter. The second thing is that time and again, people who don't want to do anything maintain that stance by portraying any call for measures as a call for restrictions, as if we want to stop people doing things, as if we are the lockdown fanatics, as if we love living in an authoritarian state. And this illustrates more than anything that we're not talking about restrictions, we're talking about safety. I mean, to call for ventilation, to call for CO2 monitors, to call for HEPA filters is not calling for restrictions, it's calling for simple measures to keep people safe. What we're talking about are those measures which keep our children safe so that we are not forced later on into restrictions. And that's absolutely clear, it seems to me. And the third thing is, I just want to put on the agenda, because we sometimes forget it, the importance of mental health. I have a 17-year-old at school. I see in his class the number of young women who have got eating disorders, the younger number of young men who have got anxiety disorders. And that anecdotal evidence is supported by more systematic evidence, which shows that up to half half of our school children are developing mental health problems. And that's not due to lockdown. We don't have lockdown anymore. It's due to the fact that their lives are completely unpredictable. They don't know whether they can plan something because they might have to stop it because of COVID. They can't plan half-term holidays because they might be forced to stay at home. They don't know what's going to happen to them. They don't know their future. And the cost in terms of mental health, I think is extraordinary. And I do think that when we're talking about rebuilding, we've got to make sure that we give the support to children. We don't only talk about physical health, but we make sure that the resources and the support around mental health is there in schools. And if I had to say one thing, which I think is the biggest cost of this refusal to keep our children safe, when, as we've seen, it's so easy to do it, it is the fact that we are ruining the mental health of a whole generation. And to me, that's completely and utterly unacceptable.
Thank you very much, Stephen. Some really important points there. Carl, I saw that you had your virtual hand up again. Did you want to make another comment, or are you happy to move on to another question?
If I may. Concerning the CO2 meters, I just wanted to add some things. Luxembourg, for instance, so the country Luxembourg, the tiny country of Luxembourg, bought in December 2020 already CO2 meters for all their classes in all their schools, every class in every school. So that's an example, a good example. Concerning ventilation and air purification, I think we need both, because we have another problem as humankind. It's global warming. And if we're going to renew all the air, 6 air changes per hour at least needed, concerning, for instance, Harvard, concerning the German Aerosolgemeinschaft, we need 6 air changes per hour. This is going to cost enormously on energy, and energy prices rising. So I think the combination of ventilation and air purification will be needed to attack also this problem of global warming. For the values that have been seen in classes, for instance, there is research that shows that after 15 minutes in a typical classroom with all windows and doors closed, researchers find that the values of the CO2 rise to 3,000, even 4,000 parts per million within 15 minutes. And there is no good reason not to install a CO2 meter in every classroom, because it costs a good CO2 meter. The Germans have tested them. It costs 70 euros, 70 euro for one CO2 meter. So count the number of classes in your country. It's nothing on a budget of education. In Flanders also the government the Flemish government refuses them, and I heard 2 arguments against them. And one of the arguments was that children, so until 18 years, 6th secondary, will be afraid of the light and the beep of the CO2 meter. That was one of the arguments by the government. And so, it's not serious at all. The second one I don't recall anymore, but it wasn't better than that. And what I also see concerning the masks in my country is many people, also politics, even journalists, they tell that putting off the mask, now we're going to put off the masks and we have our freedom back. I think a mask is not stopping our freedom. We're just more free with the masks. It has nothing to do with freedom. I think that's it's populism, nothing more than that.
Thank you very much, Carl. I mean, I think that Stephen Reiter put it very clearly. We should be thinking about these mitigations in terms of measures that we can take, which allow us to keep our freedoms rather than risking any further restrictions if it all goes wrong. Thank you very much, Rachel, for that question. And we've had a really interesting discussion off the back of that. We've got another question now from Graham Long. Graham, are you there with us?
I am indeed.
Graham Long. Yes, lovely. We can see you. We can hear you. Go ahead.
Hi. Good afternoon. I'm chairman of a parish council, and on May the 7th, it became illegal for a parish council to hold remote meetings. We're not allowed to use Zoom or Teams, etc. So I bought myself a portable CO2 monitor. I don't know if you can see that, which says that in my room here, it's gone up to 1,000 because I'm breathing on it, I suspect. But I take that with me whenever I go to a meeting. And if the figure gets over 1,000 or 1,200 in a room, I leave it. But on the point of education, my understanding is the Department for Education has ordered 300,000 CO2 monitors for UK schools. But this morning, the website Schools Week has said that 1,008 schools are due to receive 13,241 monitors by October the 15th. That represents 5% of the 21,000 schools, state schools in the UK, and just over 4% of the 300,000 promised. In the meantime, you've heard about Kettering, and I understand Amber Valley has also got similar numbers. My question is, should schools close if they cannot maintain CO2 monitors in classrooms below 1,000 or 800, as we heard earlier? And that's if they actually know the CO2 levels, but judging by the number that are out there, not many schools do.
Thank you very much, Ben. I mean, it is a tricky thing, isn't it? If we've got, as we heard from Tricia Greenwalsh earlier, recommendations of lower limits in a time of COVID, which are substantially lower than the limits that are currently recommended by HSC. But even the limits with HSC, I suppose the process with that is that if you are exceeding those, then you are considered to be in an unsafe workspace, and you should leave that workspace. I don't know. I mean, what is the situation here, Professor Deenan Pillay?
Just Graham, thanks. A really important question, and I think this gets to the heart of things, because of course we don't want schools to close. We as a group, and I don't think parents or society want schools to close. But one of the worries I have in the narrative here is this focus on purchasing CO2 monitors, the purpose of which is to identify whether there's excess, where there's poor ventilation. And then the point is to do something about it, So CO2 monitors on their own have a very limited purpose unless there's some mitigation. And that's why it was really interesting to hear from Carl and Trish about air handling devices that need to go along with that in the case of schools which may just have structures which make it very difficult to improve ventilation, through window opening and so forth. So all I would say is that the narrative does need to change into, if CO2 monitors are being purchased, then there needs to also be a focus on investing in mitigation. Otherwise, we're left exactly as you've said, is we're identifying too high levels of CO2, and then the logic is by HSE standards and so on to close schools.
Thank you very much, Dean. And I mean, it is reminiscent of discussions that we've had before, where we've said with testing for a coronavirus, that's great, but the testing is there. It has to lead to something, and without the kind of closed loop of find, test, trace, isolate, and support, testing on its own isn't much use. And it's the same with carbon dioxide monitors. Gabriel, you wanted to comment here as well.
Yeah, I agree with what Dean said, and I do wonder about this. This mass purchase of monitors and scattering them around as if they're fairy dust and they're going to make some sort of difference. I mean, let's be very clear. If monitors are going to be used, these are scientific measuring instruments that need to be used properly and to give accurate results. So they should be hardwired or plugged in. They should be mounted to a wall between 3 to 6 feet above the floor. They should be at least 5 feet away from doors or windows that might be opening to give accurate readings. And the reading the monitors need to have a memory function that maintains that reading and keeps a record of it. All of that is otherwise. They really are, licking a finger and putting up in the wind. And then when the levels are exceeded, there does need to be guidance on what should happen. And here there is the real problem, as Stephen said. What we need is a whole cadre of people who will have be trained to be able to make an assessment of the ventilation requirements in a room, whether it be a room where a parish council is meeting or a room where children are at school, and to advise on what needs to happen in order to improve that situation. And they need to be trained to do that, and they need to be operating against specified standards. And at the back of it, we need heating and ventilation engineers to be advising on what can be done across the country to improve the systems. And none of that is present. So I really regard CO2 monitors as just one tiny bit of the process. And I fear it's being used as a smokescreen, to use an airborne analogy, for a program that isn't really designed to do anything useful. I wish there were a program of useful interventions.
Thank you very much, Gabriel. I'm going to move on now, and I want to squeeze in quite a few more questions. So now I'm going to ask the questioners to keep it very short and simple, and one question only, please. Don't duplicate. And also, I'm just going to allow one answer per question so that we can get through quite a few, if that's okay. So now I'd like to invite Ian Miles to ask his question. Ian Miles.
Thank you. I'm asking on behalf of Claire Degenhardt, who isn't able to take part right now, but she's asking whether air purifier, which meets HEPA standards, is still effective in a room when the windows are open. And if it's a choice between an air purifier or an open window, which would be most effective in removing viral particles?
Thank you very much, Ian. Carl, is that a question for you?
Oh, it's a difficult one. I think the setting plays a role in education or in settings where cognitive performance is important. I would give more priority to ventilation. In other settings where learning and cognitive performance is less important, air purification can have a bigger part of but play a bigger role. But in every setting, I think both are important. Concerning which technology is most effective, well, also that's a difficult one. I've read several research. And one time it's ventilation that's most efficient. The other time it's air purification that seems most efficient. According to me, I think they are rather equal effectively.
Thank you.
Thank you very much. And the other part of that question, Carl, if I could press you on that, if it is an air purifier with a HEPA filter effective in a room with windows open, can you use both? Yes, you can use both, indeed, of course, because even if a window is open, you don't have a guarantee that CO2 levels are okay, that the air quality is okay. For instance, a window is open and outside there's no wind. Well, if there's no wind, or if there is not enough temperature difference between the outside and the inside, there is no driving force, and there will be no fresh air in the room. So in such occasions, the air purification, will be very useful. Thanks very much, Carl. Thank you very much for that, Ian. Moving on now to a question from Nigel Nelson of the Sunday People. Nigel.
Hi, Alice.
A single question, please.
Single question, very quick. Some parents are still concerned about jabbing their children. And if the best form of immunity is natural immunity, and a child has just had COVID, as we've had in our household here, do they still need to be vaccinated?
Thank you very much, Nigel. Now, I'm not sure that the best form of immunity is natural immunity. Is this one for you, Deanan?
Well, I would just, can I just call on one of you who've just been part of the publication about vaccines in children? You're ideally placed to, and it was published a couple of days ago. So can I invite one of my colleagues to comment?
Yes,
I can comment,
Christina.
but that doesn't really answer the question about natural infection versus vaccination. It's just that we know the vaccines are extremely effective in young people, but Helen might have something to say about this.
Hi. I think the issue really is that the judgment that came out saying that it was a finely balanced decision about whether or not teens should be vaccinated, I think has led lots of people to assume that the vaccine must be in some way risky or dangerous. Because we know that COVID is risky and dangerous, and although most children have a mild illness, some go on to get long COVID, and their concentration is impaired. They miss out schooling, and a few unfortunately get really, really ill. And what we know about the vaccine is that nobody gets really, really ill with the vaccine. There have been some reported cases of heart inflammation. They're quite rare, and they were all quite mild, and everybody got recovered completely from those side effects. So actually, the vaccines themselves are really, really, really safe, and COVID is not safe. Now, I think it's a really interesting question about whether once you've already had the illness, is that enough? Do you need the vaccine on top? And I honestly think we don't know the answer to that question at the moment. But I think it's, I would urge parents of children to take up the vaccine, because we don't know that answer about the response to having had an infection, and we do know that the vaccine is very safe. I'm not sure that completely answers your question, Nigel, but that's the best as I can do.
Thank you, Helen. And I was recently looking at what the British Society for Immunology was saying on exactly this question, actually, Nigel, and they're very clear about it, actually. And I've just shared the link in the chat for those of us that are here live. And they say it is likely that for most people, vaccination will induce more effective and longer lasting immunity compared to natural infection. So that's very clear. And even if you've had COVID-19, vaccination will boost whatever immunity you have from natural infection. So that is the line from the British Society for Immunology. Thank you very much for that question today, Nigel. And let's have another question now from Desmond Wims. Desmond.
Good afternoon, everybody, and thank you very much for giving me some time to talk to you. Thank you also all for your excellent work, being a focal point of integrity, clarity, and sanity in a very difficult world. So could I just ask, this is from a perspective, I have until recently been a senior health advisor for DFID for many, many years, most recently in Malawi, and doing what we could there to help them put mitigation and prevention and infection control in place. And right from the early days of last year, it was very, very clear, thanks very much to much of your work, to see ventilation as a key point. And that in itself has been a big struggle. For me, the filtration argument is extremely important. And I think my question, my query and concern is for low resource settings in poor countries and facilities, the cost of the equipment, the cost of filters, the responsibility for changes, the potential noise and waste that the filter units create. Is this really the best option for many of those settings? And that's where, just to echo back to what Carl said, different opportunities, different options for different settings. Are we overlooking the very long track record of excellent clinical impact of ultraviolet germicidal irradiation, if properly installed, which can be incredibly effective at disinfecting air in educational and in clinical settings? And I particularly, I mean, I'm not an expert on this, I'm a public health person, but William Barnsleth, the ex-chief of ASHRAE, Professor Jimenez in Colorado, and Tressa Nardell in Harvard have made recently very, very convincing arguments that this is a much overlooked mix of the contribution to the solution. Thank you.
Thank you very much, Desmond. So use of UV then as a device. Gabriel.
Yes, I mean, I have a lot of sympathy, Desmond, with what you say, and there's no doubt about it that some types of ultraviolet light can be extremely effective. I think the problem at the moment is there is a lack of adequate sort of products in the market that can combine HEPA filtration with working ultraviolet light systems. And the reasons for the caution is very substantially to do with both that gap in the market, but also a realization that some ultraviolet light can be harmful to human beings as well, and that unlike the filtration system, the ultraviolet light needs to be machinery needs to be very well designed in order not to run the risk of that danger. Now, at the back of this, could I say to you that I think one of the problems we have at the moment is that we are dealing with this new situation with this highly transmissible virus, and we don't have a standards body that is able to set proper standards for the filtration machines that we need, particularly for the ultraviolet light sterilization approach as well. And this would be something that should be being done nationally, but it should also be being done internationally. And the last time, for example, I looked at it might have changed over the last couple of months. Last time I looked at the FDA in the US, for example, they had no approved ultraviolet machines at that time. Now that may have changed. But my point is, it's a bit like setting the standard, what we were talking about earlier, the standards for the use of CO2 monitoring. We do actually need standards organizations to set appropriate standards that can then be followed, and a workforce then that can help people choose, in light of those standards, what machinery they use, install it, and have it operating properly. And I think that goes for countries right across the world.
Thank you very much, Gabriel. And all right, Anthony, you can have a quick word. You'll need to unmute, though.
Sorry, am I all right? Can you hear me? Yeah. So Desmond has worked in Malawi, and I've worked with Malawi for the last 20 years off and on, and I've visited many schools there, and many of them, of course, have no windows, open doors. Many of them are sitting outside, and they also get a lot of solar radiation, so presumably ultraviolet as well. And I've often wondered that the low rates, or apparently low rates, of infections and deaths in many African countries is because of the greater outdoor experience, and that actually that may be one of the main factors contributing to that. So the idea of bringing in ultraviolet gadgets and stuff to a very poor country like Malawi strikes me as possibly not cost effective.
Thank you very much indeed for that, Anthony. Right, I think I'm going to have to bring it to a close. I would have liked to squeeze in even more questions. It's been great to have this focus on ventilation today, and to think about that particularly in relation to education. Thank you very much, Carl von Kierswilk, for joining us today with your particular expertise. Thank you to all the scientists of Independent Sage, all of whom are volunteering their time and expertise here. And now they are all brilliant, but special congratulations again to Christina Pargle on her BMJ Award for Science Communication. Thank you to everybody who's watching, and to those of you that have contributed questions today as well. All of the reports are there on the website, and also Independent Sage tweets daily with updates on the coronavirus pandemic. So please continue to follow us on Twitter and spread the word as well. And do send us your questions ready for next week. We will be back same time, same place next Friday. Stay safe, keep well.
Bye.
Bye.
Bye.